unprecedented number of people have died from alcohol and drug overdoses in the past year. Overdoses claimed nearly 89,000 lives in the year leading up to October 2020, a 30% increase over the previous 12-month period. Every part of our healthcare system has a role to play in addressing this epidemic, including hospital emergency departments.
Many hospitals around the country are adopting evidence-based practices to meet the needs of patients with substance use disorders. To start, they provide a medical screening to identify patients with these conditions. For patients with opioid use disorders, emergency departments follow evidence by offering buprenorphine to treat withdrawal and suppress cravings. At discharge, evidence supports providing all people with substance use disorders an effective referral to community-based care and access to naloxone for those who use drugs that may contain opioids. These three practices are endorsed by the American College of Emergency Physicians.
And yet, in far too many communities, hospitals are not implementing these practices, even though they fit squarely within their role in addressing acute emergencies, reflect the services provided to patients with other medical conditions, and can save lives.
As we've seen in other healthcare contexts, these practices may have a disparate racial impact on Black, Brown, and Indigenous people. Communities that have experienced the steepest increases in overdose rates nationally, and in some areas have the highest rates of drug and alcohol use disorders. The adoption of evidence-based practices will mitigate racial disparities that arise because of provider bias based on disability or race. Our key finding is that hospitals that do not adopt evidence-based practices may risk legal consequences. They could violate a patient's legal rights under several federal laws. First, the Emergency Medical Treatment and Labor Act, known as EMTALA, requires hospitals to screen every patient who comes to the emergency department, identify emergency medical conditions, and then provide treatment to stabilize the patient to reasonably ensure that their medical condition does not deteriorate after discharge. Emergency rooms can violate this law when they fail to screen a patient for substance use disorder, administer buprenorphine as appropriate, or provide a facilitated referral to treatment. Hospitals may also violate two federal disability rights laws, the Americans with Disabilities Act and the Rehabilitation Act. These laws prohibit hospitals from denying health services to individuals with substance use disorders, including people who use drugs, based on unfounded stereotypes. Emergency departments that resist the adoption of evidence-based practices often rely on stigmatizing views about patients rather than objective facts when making their care decisions. And finally, a hospital could be liable for race discrimination under Title VI of the Civil Rights Act if it intentionally denies a patient evidence-based practices because of race or ethnicity, or if it administers or fails to provide these practices in a way that has a disparate racial impact on access to care. All hospitals should understand the urgency in adopting evidence-based practices for patients with substance use disorders. Our examination of legal liability will add another compelling reason for hospitals to adopt practices that are life-saving and at the core of the emergency department's role in our healthcare delivery system.